Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my good friend and colleague, Dr. Lejla Vajzovic. She is a vitreoretinal surgeon and tenured professor of ophthalmology at Duke University Eye Center. She's also director of Duke Surgical Vitreoretinal Fellowship and CME, as well as co-director of Duke Pediatric Retina in Durham, North Carolina. Welcome, Lejla.
Thank you. Thanks, Arshad. It's a pleasure to be here.
Well, I'm sorry that I didn't read all your titles. You have a lot of titles, and that's because you're so good at what you do, and you have really done a great job over the last, decade or so in terms of elevating Duke Eye Center, as well as, really innovating in so many different areas, not just one area, not just gene therapy, but pediatric retina, in imaging and also in surgical aspects. So I'm very excited to talk to you because I think you're an inspiration to a lot of physicians who are in training and who are practicing. So I'm looking forward to our discussion. Of course, it will focus today mainly on oral and systemic treatments for geographic atrophy, but I think before we get to that topic, it's always good to learn a little bit more about our, faculty that attends these podcasts. Of course, you have done this podcast before, and you are here the second time, and only very few people have made it second times very quickly. So congrats on coming back to Retina Radar, and I'm looking forward to our discussions.
Thanks, Arshad. Pleasure to be here. Thanks for having me again, and right back at you. Truly honored to do this, but really admire all the work you've done over the years and bringing our field forward.
No, thank you so much. Okay, so I think people know your career journey maybe, but why don't you remind us about how did you get into retina? How, what inspired you to do pediatric retina and the career you took in academic medicine?
Yeah, well, certainly. Well, I think we all are drawn to retina for various aspects, but I think for me, it was truly kind of intersection of doing microsurgery. Even back in medical school days, I was dissecting a little bit my size for ROP project, and I just really enjoyed really microsurgery. I found it kind of just, to be honest, calming, so to speak, to be working on such a small but yet with precision. And it got me interested in microsurgery there. But then throughout my journey at Bascom Palmer and Duke Eye Center, I was really drawn to some amazing mentors throughout my training who were specifically in retina, and all the amazing drug development, but also imaging development they've done over the years. So I saw how exactly the retina world especially brought together innovation, not only in providing the next generation drugs and therapies, but also innovating imaging technology. Really was a merger of surgery, imaging, and innovation all in one. So retina was naturally something I really wanted to do from those exposures. And then coming to Duke, I love the fact that it really allowed me to intersect with engineers who are very much on campus, the scientists at Duke Eye Center who are doing basic science work in ophthalmology in general. So all of those exposures and environment altogether really drawn me to continue my interest in retina and to be really involved in imaging research as well as the next kind of drug development in our world. So I love our retina community and environment. I think it really brings together a lot of innovation in every aspect.
Wow, what an amazing journey. So if you had somebody, and they all come to you and they look up to you and say, I want to be like Lejla Vajzovic, what do I need to do? What would you tell them?
Well, I think all of us love what we do. I think you do a good job if you really truly enjoy what you do. So first and foremost, I tell it, like, ask yourself, what do you enjoy to do? What do you like to do? What would you love to do? I think it's seeing your mentors doing it and shows you're a role model, so to speak, where you may inspire to do that and continue that trend. But bottom line is, I think you really see in every profession, the people who enjoy doing what they do it really well. And I absolutely love my job. I love every aspect of it. I love the fact I'm interacting with trainees. I love the fact I'm doing surgery and latest and greatest surgery in terms of involved in some of these latest techniques or in clinical trials. And I love the fact that I get to interact in clinic, not only with adult patients, but pediatric patients. Those may be very challenging to deal with. Most certainly talking to families is a challenge, but I find it so gratifying. I find it even more so gratifying because changing a site for somebody who is early, even a premature baby or just a baby, and changing their trajectory and their exposures in life by saving that vision is it's definitely gratifying. So now that I'm decade plus in my career, when I see those kids coming back, now being in middle school, high school, even further out, and all the things they've accomplished in their life, it's really, really inspiring. So I find that very gratifying. Hard work, but really gratifying.
Yeah, definitely. I think one thing I know about you is you work really, really hard. I mean, you are in Paris one day, North Carolina the other day, then you're in Chicago, then you're back to somewhere else. And I mean, I thought I travel a lot, but looking at your schedule is always inspiring that how you manage. So I think the other advice I'm sure you will give it to anybody who wants to be like you is that it requires decades of hard work and commitment. But of course, as they say, if you don't enjoy what you do, then it's not worth doing. And if you enjoy what you do, then you're not working a single day in your life. So I think that's a really good advice. Okay, quickly, I know you're a big skier. Is that still your favorite hobby?
Most certainly. Definitely grew up downhill skiing. I absolutely love it. Wish I had more slopes around me. North Carolina has a few, but really miss that aspect in my life. But as you know, Arshad, I find ways to make it to the slopes no matter what, during wintertime especially, and I really enjoy that. I love the fact that my entire family enjoys it. I think it's a great family activity, one that really puts you outdoors, but in really just absolutely love kind of seeing snow-capped trees and everything on the mountain, especially after a fresh snowfall. It's absolutely memorizing.
Yeah, you're always welcome to visit us. We have pretty nice ski resorts in Lake Tahoe, Reno area. Okay, let's go to topic at hand. Geographic atrophy is a disease we all see on a routine basis. You've been in practice over a decade, and you have seen patients who are 20/20 and now they're legally blind. It's a relentless progressive disease. We have, available 2 FDA-approved drugs. Great to have them, but obviously the challenge is treatment burden and compliance, and obviously the efficacy that is modest, and of course some safety signals. So as a field, we are looking for other things. So I think I wanted to really focus on the oral and systemic treatment for geographic atrophy with you, because you've been deeply involved in many of these programs, because of obviously your interest in Stargardt's disease as well as geographic atrophy. And so I think first thing is like, do we need oral or systemic drugs for GA? Do you think doctors and patients are actually gonna want that as an option for geographic atrophy?
Arshad, like you pointed out, I think complement inhibitors were a major step in our field. They're really super exciting to have, first ever approvals for such a common problem that we deal with. And I think it's important to, point out that they don't restore lost vision. They still require frequent injections. I think that burden is there. They require monitoring and really the risk trade-offs, so to speak, to doing intravitreal injections for sure. Patients often require bilateral treatment and getting bilateral injections routinely and commonly. It's definitely burdensome for sure. And then, with intravitreal injections, it's very hard to start early in the disease. I mean, your asymptomatic patients that you really want to have on intravitreal injections to decrease their progression, that's a hard sell because they absolutely are not having any symptoms at that time. And yet, what's coming. So oral and systemic therapies for that reason, I feel like they would really be helpful, especially early in disease. First of all, we would treat both eyes simultaneously. So that's a benefit of taking oral systemic therapy. We can start earlier in disease. Somebody who is asymptomatic is not going to object to taking a pill as much as getting intravitreal injection. And I think, reducing the treatment of just burden of coming to our office to get those intravitreal injection versus just taking something that's at your house would be much more convenient. And then hopefully we're targeting different biological pathways. In this case, there are options for potentially targeting vitamin A dimerization, mitochondrial dysfunction, like potentially attacking it from different. We all know this disease is multifactorial, and who knows, maybe all of these at the end will be additive as well. So I think all of those options are most certainly positives for oral systemic therapies.
Very well said. I don't have much to add about what I think. I think you covered it very well, right? No burden at home, bilateral effect, and really very convenient. Obviously, they need to have efficacy and safety, right? People worry about systemic drugs because, we didn't go into internal medicine for a reason. We don't want to manage liver labs and kidney labs and all that. So, okay, so let's go into some of the exciting programs that we have. So first one, I think the one that's quite far ahead in terms of development is an oral pill, Glider-retinol or ALK-001. Can you tell our audience quickly about the mechanism of Glider-retinol and how it works? And then we can dive into some of the data. I know they studied in Stargardt disease, and they also recently released the data from the Saga study in geographic atrophy.
Yeah, most certainly. So Glider-retinol is a form of vitamin A, which is designated to slow the formation of toxic vitamin A dimers. So it really helps with the buildup in retinal pigment epithelium. By reducing these byproducts, it may protect photoreceptors and RP, and therefore slowing down the GA progression. Glider-retinol is not a visual cycle modulator. That is a specific distinction I want to make because it's commonly confused for that. So it does not block the visual cycle, which means it really provides normal vision processes and that are preserved and without any side effects of really the delayed dark adaptation that would anticipate when any true visual cycle modulator. So all in all, we are talking about oral therapy that is preventing the vitamin A dimer formation.
Got it. I think it's important to know that it's not visual cycle modulator. Okay, so can you tell us a little bit about some of the data to date we have from the studies, especially the GA study?
Yeah, well, certainly. So you nicely pointed out that it has been studied in Stargardt's as well as geographic atrophy. And then most recently, Saga trial data was released. It's a phase 2 trial that provided first signal by showing that it really decreases vitamin A dimerization in this important common disease. And what it showed clinically meaningful trends towards slowing down geographic atrophy by about 13% or so from 0 to 24 months. So that was the primary endpoint. It also shows us statistically significant slowing geographic lesion growth from 6 to 24 months. So really seeing even more so effect from 6 months on compared to placebo. Lastly, it showed that visual function benefit was also seen by fewer letter loss. 4.4 fewer letters lost were seen in low luminance visual acuity over the 24-month period. And why is this specifically important? We know our patients with geographic atrophy had much difficulty seeing in darker settings. That's typically the first complaint we hear. So for this first investigational therapy, I think it does show for the first time as well functional benefit in the low luminance visual acuity. And then safety is always a very important in early phase trials and any phase trial, but we're focusing on that specifically in phase 2. And majority of adverse events were mild to moderate, and the safety profile was very favorable with no reports of delayed dark adaptation, chromatopsia, or vasculitis. And I also want to highlight that while safety looked excellent in GA program, I also want to include the Stargardt disease program. And if we look at both Stargardt and geographic atrophy clinical trial, over 400 patients were enrolled across both programs. And I think that the fact that such a large number of enrollments seen with excellent safety profiles in both programs tells us that this is potentially a very promising oral candidate for geographic atrophy.
Yeah, very, very exciting data. An oral drug to slow down GA and not having systemic side effects. I think, and as you mentioned, there was the LLVA data is also intriguing, that if you can have a functional benefit of some sort, right, in the next trial, I think that would be important, because that's the reason that the complement inhibitors in the trial didn't show that, and that's why they're not approved in most countries outside the US. Okay, so another exciting program is ALBIA-008, which is also being studied for GA in the phase 3 Phoenix trial, which is ongoing. They also had some, data in Stargardt's. Can you tell us a little bit about that mechanism of action and how is this different than glider-retinol?
Well, certainly. So this is an oral RPB4 modulator. So it lowers the delivery of retinol from the liver to the eye, which really turns down bisretinal formation. Lots of fancy words for really truly modulation there. As you mentioned, the Phoenix phase 3 trial is a 24-month placebo-controlled study in geographic atrophy. This is, again, looked over a extensive time period. Enrollment just finished in 2025. So it hopes to really see slowing down geographic atrophy growth and maintenance of function in overall with once daily oral dosing. So it's exciting to have more and more potentially oral therapies that are in clinical trial development and hopefully will be available for our GA patients.
Got it. And then, so what is the difference? So this is a visual cycle modulator. So there is some dark adaptation changes and some vision loss at night. I think that was seen in their Stargardt. And how does that matter in terms of geographic atrophy? Because patients already have, contrast issues and low luminance deficit, as you said.
Yeah. So hopefully it will decrease the amount of or progression to and further difficulties in night vision.
Got it. Okay. Okay, great. And anything else oral that you're excited about before we move on to systemic drugs?
Yeah. I think in general, I guess that would be for oral. Other exciting things would be subcutaneous treatment daily. That is, I think, again, promising. But as you point out, systemic therapies are next.
Okay, great. So systemic therapy, let's look at phase 3 programs. Almapritide is in phase 3. It targets mitochondrial dysfunction. And we had, data from their phase 2 trial, which guided the design for the phase 3 program. Can you tell us a little bit about almapritide just overview some of the data that we saw and what are you excited about learning in the phase 3 program?
Yeah. So like you point out, it's mitochondrial targeted peptide. So it binds cardiolipin in an inner mitochondrial membrane and aiming to really improve mitochondrial energy production and reducing oxidative stress. So this is really the principles behind it. In Reclaim to trial, this is a daily subcutaneous injection was shown to be safe and show promising signals in terms of photoreceptor structure and functional preservation. I think that's super exciting to now have to talk about ellipsoid zone metrics. And this is one of the trials that can introduce or continue to introduce importance of easy preservation as well. While GA area reduction needs more confirmation in these trials, I think it's promising to have a new kind of novel target with mitochondria in question. And then I would love to see this pans out for geographic atrophy as well. Again, lots of trials looking at different aspects of attacking towards the GA. So who knows, maybe all of these will complement each other in the future.
No, I think that's a great overview, and I agree with you. I think mitochondria are sick, right? And it's an age-related issue, of course, genetic issue too, AMD. And I think re-energizing the mitochondria and try to get the energy back in those photoreceptors may lead to preservation, and that's why I think ellipsoid zone is an important endpoint, right? So this is the first phase 3 program in Renew and Regain where ellipsoid zone attenuation is being looked as a primary endpoint and not fundus autofluorescence, GA lesion growth. So I think, yeah, very, very exciting. Obviously, do you think that patients can inject themselves daily? These are elderly patients, or they need to work on longer acting formulation?
Yeah. I mean, most certainly, I think for all of us, be it oral or subcutaneous, longer acting, the better. I think compliance always comes into question. I know how difficult it is for me to remember taking a pill daily, as simple as a vitamin, as well. So I think that holds across the board. I do think that taking a pill is a little easier than injecting yourself. But I do, depending what the results are at the end, I do think there's some training involved for our patients to understand how to do that. And I doubt it would be a much of a burden from, with proper training.
Got it. No, I agree. And I think some of the injectables also have injection site reactions. And I think over time, that's something companies can work on, whether patients need to apply antihistamine cream or something like that when they're doing the injection every day or every week. I think that's something we're going to learn about the safety of the local site reactions, because I've seen that in many systemic trials. And you're talking about systemic trial, I presented Retina, as data about a systemic TKI that is a very different approach than regular TKI, and it doesn't have liver toxicity, and it only works on activated macrophages and glial cells, and saw some promising data in DME and neovascular AMD. So I think the field is evolving, and that's what I want to mention is that there's a lot of systemic treatments that are being studied. We also have some early stage program with complement inhibition. Now that's an interesting approach, right? Because you're shutting the systemic complement down, or you're going to end up with pneumococcal or meningitis and and other diseases. That's why you need to have vaccinations. So I think the field is looking at multiple different approaches. The good thing is that there are many shots on goal here in terms of systemic and oral, and if we can take one or two to the finish line, I think it's going to be very exciting. So Lejla, let's envision that you have a pill or a systemic drug approved, and then you also have your intravitreal complement inhibitors, and let's say the efficacy is similar. Like, I know you mentioned like systemic mainly for earlier disease. Any other comments on like how do you plan to use these different options?
Yeah, no, I think most certainly oral would be easier. Subcutaneous, I think it would be next in my mind if all is safety and efficacy looking good. And then lastly, intravitreal. Bottom line, we're going to use what's going to be the most efficacious and safe for our patients. So I look forward to seeing these clinical trial results. From kind of expectations, I would expect for patients to find it easier to take something at home or do something at home versus come to us in office to get the therapy.
It's always great having you because you make it so simple and easy to understand. Okay, now moving back to your career, couple of questions we always ask before we end the podcast. We have a few minutes left here. So you've done a lot, many awards, tenured professor at Duke at such a young age, presenter at every meeting, tons of publication. Tell us, what are you most proud of in your career in terms of your career achievement at this stage?
What I'm proud of is really the team that I have built at Duke. I think mentorship and team building is very important to me. And I'm truly proud to have amazing team that I work with at Duke, from clinic to OR to my research. They really inspire me every day, and working with them is really gratifying. So I find that I aspire going to my clinic when I see my coordinator who's been with me from day one. I absolutely love working with her, and you're nodding your head because you know that you have those individuals that you just have gone through your career with, and you're like, gosh, you make my day every day I see you. So yeah. It's exciting to have built that team and to have gone through various stages, various milestones, not only in my career, but also my personal life. So I find that that is really the proudest thing I am about having this central team that especially has been there with me for a while.
No, you're right. I mean, it's all about the team, right? Sometimes we get the limelight, but the hard work is done by team. And I think one of your coordinators was on a panel recently at an investigator meeting, and they were phenomenal. So yeah, keep up the good work there. Now, other question we asked before we close is, how do you want to be remembered as, when you're done doing retina, another 40 years, 50 years of practicing you, but how do you want to be remembered by your colleagues?
At this stage of my life, I really enjoy spending time with my family, kids, and I absolutely love my girls. So while there's, many things we do in our career, I really just want to be remembered as a proud mom of two. So.
No, that's and you do a great job, excellent mom as well as a very successful career. It's not easy to do. So thank you, Lejla Vajzovic. It's always a pleasure speaking with you. I learned a lot about systemic and oral treatments today from this discussion, and also getting to learn more about your career. Hopefully our audience learned a lot about you, and you can inspire many of our listeners. I really appreciate your time, and also want to thank the audience for listening in. Thank you, Lejla, for joining in today.
Thank you, Arshad. It's always a pleasure. Thank you.
To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.